Yeah. No. We've done this.
You're good.
What about this one? What is the one consistent factor linking your friends despite how different they may be in other ways? That's nice.
What are you guys? Which one? The last one?
Yeah.
It's like from the.
Oh, we should.
Yeah,
Complex question.
yeah, but anyway, good morning. I guess we're gonna start since OBCC is over. We're quite a schedule. We're gonna have our clinical case review, then I guess Leshae, I forgot. Are you doing journal club on the LGA RCT? And then we have a bunch of blurbs. I think Yen may be doing some, Sophie may be doing some. Is that correct? I think so. That's what she told me. Anything else on the agenda otherwise? So, major announcement, the dean was, with us at faculty meeting this morning and announced that Dr. Janelle Coleman from Hopkins has been appointed the new chair here at Center City Jefferson, also the new enterprise chair for the whole place. She's the head of GYN at Hopkins, went to school at Penn, is originally from Philadelphia, and she's a long CV. I'm not gonna go over her CV. She interviewed here. We know her. I think she was selected because of academic credentials. She's an R1. She's published. She heads there again the division and a few other things. Hopefully, leadership skills and diversity, community reach, and all the stuff we all care about a lot. I think they say the date to start is November 10th. And we look forward to that. Sandra obviously will continue as interim, till then. She doesn't know what she's going to do. I emphasize to the dean and the powers to be how wonderful she's been, how great she's been to our division, to the department in general, and personally, I hope she stays in some role. And that's it. So major thing. It was a long search, and I'm glad it came to a close. Look forward, hopefully, to growth and new things. Any other announcements otherwise? No, you guys are good. So the question again, not the easiest, but let me see. What is the one consistent factor linking your friends, despite how different they may be in other ways? I thought about.
Yeah,
Go ahead.
complex. But I was thinking about it. Like I have friends from high school, med school, residency, and I think actually the differences are the one who make us together. We're different.
Mm-hmm.
We complement each other. We're
Beautiful.
And the things that link us the most is our memories. Remember when you did it?
Yes.
Each time we meet, it's like
Beautiful.
this day. And we laugh about it again and again. So the memories are important. I guess that's why I take pictures of everything.
That's a great answer.
For me, I think it would be our values that are probably the thing that links us the most together. Because I have friends obviously from like different stages of life, from like Dr. Roman said, like high school, middle school, and then now obviously residency and fellowship. And I think it's just the values that we all share.
I was gonna say the exact same thing. I think most of my friends actually are in medicine, but like my college friends, like most of them also went into medicine. So I feel like we all kind of went into it kind of with a sense of social justice and kind of serving others, and then also being from like immigrant backgrounds and kind of having that like shared kind of I guess grit from from families. I feel like, yeah, and also just curiosity about the world and kind of like I travel, like sharing memories, traveling together. So yeah.
You took the flip. What is the most consistent factor linking your friends, despite how different they may be in other ways? Maybe Leshae goes first, and then we go to Paolo.
I have two different friend groups. I would say the friends that I grew up at home with, like went to high school, primary school with, and I tend to maintain very lifelong friendships. And I think my childhood, high school friends, we're kind of bonded by our shared love for our culture, kind of values growing up, different, like similar backgrounds. And then my friends from like med school, residency, now fellowship, I think, like Avisha said, like values, and kind of shared love for medicine. Yeah, that was a tough question.
Yeah. Good, Paolo, any answer to that?
Yes, I have many friend groups, but I think I share my times mainly with my colleagues, which have become my best friends in the last year, my residency colleagues, and so on. Of course, the passion we share is the passion for medicine, for obstetrics. Yes.
Great.
I feel like all my friends like across my life have been pretty different. I still have friends from like elementary school and high school and college and my research year, but I feel like everybody's really curious about the world and like trying to figure out how to make it better in some way. And I think that's like really important to me too. So I feel like that's kind of the one linking factor.
Again, welcome you through the meeting. Good morning.
Hi everyone, I'm Kate. I'm one of the sub-Is on MFM. So I would say for my friend group prior to medical school, I played field hockey. Field hockey was a huge part of my life. I played travel and then played in college. And so like joining a competitive sport, you kind of have a built-in friend group because you're, practicing for 3 hours a day. And so I think despite all of our differences in that built-in friend group, we all had a shared understanding of like the importance of dedication and collaboration for achieving a common goal. And then of course, like my friend group in medicine, we all have very common goals of wanting to help patients the best we can and it's like that. So
I would say, my best friends and I were quite, different in our personality, but the one thing we have in common is our dedication for communication. I talk to them every day, FaceTime, and when things, are busy, we just like, okay, I can't talk, 2-second phone call, and we text and chat kind of like throughout the day, and kind of updating each other and on how life is. We're all in medicine, so it's kind of easy that way, I guess.
I think that the most consistent factor linked for my friends is like the bad and the good moments, the moments in the hospital, the moments in the residence, because my closest group of friends right now are my colleagues too, and I think that the most thing that consistent our friendship is the job. I think so.
Great. And for me, I think a couple of things. One is shared admiration. And it could be, I don't know what they admire me for, but I admire them for many different things. Maybe somebody comes up for a difficult background. Somebody has achieved great things. Somebody takes great care of their kids. So mutual respect and admiration, you kind of say that. And another thing, it's actually what links it's availability, like they want to be with me, I want to be with them. It's like in any other relationships, it takes two ways to tango, and friends who, are going to be there for you any moment, and call you, stop by, check on you. I think that's where some of the links of the different, friends, like you said, you can have in your life. Friendship is really important. The more who's going around the table, the more I like this question. It's really important for your wellness, to maintain a good group of friends and to rely on them, for your well-being. I don't know if Melissa is on and Stephanie. Again, we started a little early, so maybe they're not. I guess we can go ahead with the
We have 3 patients currently. This patient, Stephanie Medley, she was admitted overnight. This patient is 40 years old, G1P0, 16 and 6 with a history of type 2 diabetes, chronic hypertension managed with labetalol 200 BID and Procardia 60 daily, and newly diagnosed hyperthyroidism. This was diagnosed on July 30th from an ED admission. She has been following with endocrinology for management for her diabetes. Kind of a backstory on her hyperthyroid diagnosis. She presented to the emergency room with a headache and was noted to be severely hypertensive. She received a diagnosis of chronic hypertension at that time. She saw her PCP the next day, who ordered thyroid testing as a workup for primary hypertension, and her labs were concerning for hyperthyroidism. She saw endocrinology. They did a workup for Graves' disease. Her thyroid stimulating antibodies were negative. She presented to the office yesterday and saw her family medicine and recommended just feeling fatigue, malaise, just unwell. She had not been started on any treatment for the hyperthyroidism and was due to kind of follow up with endocrinology, but that has not yet happened. So the family medicine physician discussed with Dr. Gullerson, and the recommendation was to present to the emergency room to thyroid storm. Overnight, when she presented, she was initially hypertensive in the setting of not taking her medications. And after she was given her medications, her blood pressure, she had a normal tensive blood pressure. This one is a fresh one this morning. So her labetalol 200 BID and Procardia 60 is now ordered. She had repeat thyroid labs again that showed hyperthyroidism. So her TSH was less than 0.02 and her T4 was 2.0. She also had an EKG that showed sinus tachycardia. She had a pro-BNP that was 235. This morning we ordered an echo just in the setting of newly diagnosed hyperthyroidism, elevated BNP, just to rule out any cardiac and implications of that diagnosis. So the plan for her currently is to, she has an endocrinology consult in place to discuss medication initiation given symptomatic hyperthyroidism. She does not have any features of thyroid SARM. She's afebrile. Her vitals, like she's hypertensive, but she has chronic hypertension and her blood pressure is responsive to her blood pressure medications, and her mental status is appropriate. So we have not initiated any medications for thyroid storm. So we'll see what endocrinology says, follow the echo for her elevated pro-BNP, and kind of come up with a long-term plan to adjust her meds once we initiate them.
I don't know what the barriers were at New Jersey. I think they panic a little bit about the hyperthyroidism. She actually was very stable, not real indications for admission, but she was already here very late in the day. So I okay, let's keep her and review her situation and make a plan for her discharge. But she was not in any acute issue. Her blood pressure was a little bit high yesterday, 150s, but she had forgotten taking her labetalol. Once she got her labetalol, she's been okay. We're dealing now with orders for her insulin pump, but otherwise she's very steady. It's an interesting.
And you say earlier that their thyroid stimulating immunoglobulins were negative in the past?
Yes, it was
Yes.
negative, so normal. So low concern for Graves' disease.
So 95+% of hyperthyroidism is Graves' disease.
But she could be having Hashimoto's. They didn't do a TPO, which I think was pending when you review.
I mean, it's interesting from that kind of view, it's I've seen a couple of hyperthyroidism without circulating immunoglobulins, but not very many. I wonder if through endocrine you can think about any other, workup because some of those antibodies, as cross the placenta, some don't. In terms of how you're going to follow the baby, for goiter, for tachycardia. Is the baby tachycardic?
No, it was not.
Not that I'm aware of, no.
She had no
that's
viral
goiter.
infections, right? Not that we're
Say
aware of,
again?
because like a thyroiditis can temporarily cause.
Yeah,
Like a viral.
it'd be interesting, what kind of antibodies, if any, they
We
want
didn't
to
do
check.
ultrasound, right? It's like
it's
thyroid
pending,
nodules
like-
can.
Somebody ordered the thyroid studies, but she has not seen endocrinology for this specific complaint. While she has an endocrinologist who handles her pump, I don't know why it was difficult to reach out to an endocrinologist to give an advice on her management.
It was interesting because Endo saw her on 8/1, and they said like we will.
As outpatient.
Yeah, they saw her outpatient. They said we will kind of evaluate for other causes of hyperthyroidism. And they were the ones who ordered the TSI. And they said we'll kind of start medications pending what the lab results showed. But some of the lab results are outstanding.
So maybe you can call that same person.
And her doctor is Dr. Furlong, who's one of our endocrinologists taking care
Yeah.
of our patients. You can reach to him anytime. So I was just surprised to hear like they have not been able to reach out to her doctors. But anyway, she was here. So we will see what she needs, make a plan, send her back.
Next patient is a bit interesting. So this patient in 1104, Miss Tayera, she is 30 years old, G4P2012, 15 and 0, by her LMP. She was admitted yesterday for methadone stabilization. She reports use of Percocet that she buys off of the street, anywhere between 10 to 30 milligrams. When she presented, her COW score was 1. The ED, she was admitted from the ED, so they got like a standard drug screen and a urine fentanyl that were negative for any opioids. She reported her last use was the day prior to presentation. Her UDS was only positive for THC. We kind of discussed admitting her for like observation to see if she would score for initiation of methadone, but her COW score since she's been here has been 4, and her only symptomatic med that she's required is Tylenol. So I guess we're gonna decide kind of what is the plan since she's not scoring enough for us to initiate methadone.
That's good.
Yeah. So.
Right?
You were not sick, and I was like, okay, let's see how you're doing. Well, we can make a plan for her today and discharge.
Does James do outpatient?
I'm not sure.
That could be like something just to see if
She's looking into an inpatient facility, but if she's not on methadone, it's going to be complicated. So that's why I was like, okay, let's see if she scores something. Otherwise, we cannot. I mean, social worker was here this morning and
social
made
situation.
recommendation.
She says she feels safe at home. She lives with a friend. She does not. It seems like the story with her current kids is wishy-washy. She said they live with her, like her parents. Unsure she has custody of those kids or not, but she says she feels safe. She doesn't have any concerns with living situation. She wanted to meet with social work though to talk about like mom baby programs. So that was something we discussed yesterday when she initially came in. Our next patient, she's well known to all of us, I think. Miss Fermina, she's a 28-year-old G4P2012, 33 and 6 today. She was admitted on Monday for management of known hypertriglyceridemia. Kavisha actually got her outpatient triglycerides that were 1,400. So she presented for initiation of an insulin drip, which has been shown to help with decreasing triglycerides, continuation of her home medications and endocrinology kind of consult and co-management. She has been on the insulin drip since admission. When she presented,
So sorry, going back, she had a family history?
Family history of familial hypertriglyceridemia. Back in June, she was actually admitted for pancreatitis. And at that time, her triglycerides were in like the 600s to 800s. She was on Lovaza, I think BID and fenofibrate. That time was also found to have cholelithiasis, but not cholecystitis. So the question was like, can she continue with the fenofibrate? After GI and endocrine spoke, they were like, let's just continue her on with these medications, given the risk of pancreatitis. And then we can discuss whether or not we need to do a cholecystectomy like after she delivers. So we've been seeing her essentially in the outpatient setting, trending her triglycerides in addition to endocrinology. Her most recent triglycerides, which were from August 8th, were 1,400, so a pretty significant increase. And so given the elevation, essentially the question was like, this patient's at increased risk of pancreatitis. I think at the time when I spoke to her on the phone on Monday, she was 33 and 6, so she's 34 and 3.
I think she's still
she's 33 and 6. She was
33 and 3. Yes, there it is. And so then I called Dr. Watari from endocrinology, and I was like, what do we do at this point? And so she essentially had recommended there's no additional medications that we can safely use. There's a medication that recently came out, but there's actually zero data in terms of pregnancy, not even on animal studies, and like probably wouldn't be approved for insurance. So then the plan was having her admitted for an insulin drip to reduce her triglyceride levels, and then from there kind of come up with a plan in terms of when to deliver, and then whether or not she'll need a repeat insulin drip to keep those levels low to reduce her risk of pancreatitis. And that's essentially why she's here.
Is there a target or?
It's 500, because 500 is what increases the risk for
It's
pancreatitis.
working actually faster than I thought. We're almost there. We have to stop the insulin this morning due to hypoglycemia. We stopped it about 3 times already.
and we
Use a GDM too.
Yeah, but
of the drip.
I mean, we look at her diet and sometimes it's like, but yeah, we have stopped 3 times.
One of
That is
the
working.
One of the concerns too was if she was actually taking her medications, like she reports that she's taking the meds, but we actually called the pharmacy that her meds are prescribed to see when the prescriptions were last filled. And she last filled her prescriptions in May, and she's unsure of what dosages of medication she's taking. So likely, I think she's being a little facetious in her taking her meds. So we've really encouraged, like, you need to take your meds. Like, this is, even though you're not feeling any symptoms, like, this is actually very serious. So hopefully this admission, she takes the meds and her triglycerides continue to be within range.
The next question will be, when to deliver?
We're thinking like 37 weeks.
Do you have?
For GDM, she doesn't say anything or?
No, she's not taking meds.
Baby was smallish but normal. We did growth this admission. It was at
16%.
16%. Not a big baby, but normal Doppler, normal fluid, normal tracing. I just thinking that she had pancreatitis this pregnancy. She's at high risk of having pancreatitis again. The longer she's pregnant, the higher the risk. So after 37 weeks, I don't see why we need to keep her pregnant.
I think it's a good idea. I just, administratively make sure everybody knows. I don't know if you want to present our BCC and just make sure that Ryan and everybody else is okay with that earlier than that. C-section, I think
Okay.
makes a lot of sense. Another thing I think about this case is, I think you're gonna see within the next few years, 2 to 5 years, a change in practice. Like forever, we've talked about triglyceride, cholesterol, we don't check them in pregnancy, they go up, there's nothing you can do, the medications and this and that, but
Stop this happens.
it's actually, I've seen a lot of submissions of research on cholesterol in particular, also triglycerides, linked to LGA in some cases, obviously linked to cardiac disease. So I wouldn't be surprised if we're gonna test, I'm not sure if routinely, but a lot more people who may have risk factors for LDL, HDL, etc. in pregnancy in the near future. It's something we kind of ignored and stayed away from, but with obesity epidemic, diabetes epidemic, cardiac disease, more and more of a factor in mortality. DEI issues and BMP. There's all kinds of impacts, and so I'm glad we're following it on this patient, and I think we'll do it for a lot more.
There's actually just one case report on hypertriglyceridemia management in pregnancy, and there's not barely.
Really? That's what you found?
That's the only one that we found in literature search. So it's interesting. I think there's a lot to learn from this patient because a lot of the guidelines and knowledge that we have comes from a non-obstetric population.
I think the Gray will soon publish something on cholesterol, and the Pink will publish a series on cholesterol and also an editorial. And you're right, we didn't find too much, but I think a lot more is coming. A lot more data is coming. Wow.
There's something about or studies going on about statins and preeclampsia risk. So are they looking into safety and statins?
We're using pravastatin for a lot of those, but it's not really a good medication for reducing cholesterol. It's one of the worst.
Got it. Good to know.
Yeah, maybe eventually, even if you want to do a journal club or something, it's a good topic to review. There were a lot of statin randomized studies that were small or stopped. Is it safe? Is not safe? I think reviewing that will be at some point will be a good body of literature to review. A lot of strong feelings in the literature as well, NIH money, etc. Yeah. Great.
Any other questions?
That's it.
And no patients to discuss follow-ups from earlier in the week?
We added her to the list of outpatient. Do we want to add her to OBCC?
She's been on the continuity list, yeah.
No, but in the OBCC, I'll add her. It's just for model delivery.
Because
Yeah, you should add it so everybody knows 37 weeks delivery. If everybody's aware. Every delivery before 39 weeks that is not currently, preeclampsia with severe features or whatever, I think important that people are aware and agree. Thank you.
Interesting patients from the week.
I have some scans.
Okay.
No, we don't have anybody more. We did an interesting cyclage, but let's see.
Was it interesting?
It was coming from Delaware. It was almost 3 centimeters
Dilated.
With bulging back. So successful. Now we've sent her back, but it's just surprised me how MFMs around us don't do classes emergency. They go home at 5 and the patients are stranded. Sorry, I'm not going to take you. Oh.
Yeah. Speaking of circulatory, I'll steal another couple of minutes. Couple of things. One, at SMFM, the first day, it's a Sunday. There'll be a postgraduate course on circulage that many of us will be participating on. If you go that early, for the fellows. A lot of that stuff. But it's nice that SMFM recognized the importance of circulage. And then yesterday, I've been talking about the meta-analysis for cerclage in women with a singleton gestation, no prior preterm birth, and a short cervix. And actually, thanks to the reviewers, we found out that at 20 millimeters or less, and the results were significant. And now that this paper was accepted, yes, I don't know how I'm going to do this, but I guess we'll represent the data, and I think we'll that may lead to a change in practice here at other places, etc. But we'll show you that the data now that maybe I'll wait for the papers to be actually in print, and I'll show you. Very good. You have
I do. I have a couple. Did we already look at this patient for first trimester?
Yes.
Okay.
Yeah.
So I just wanted, this is a patient we've reviewed before, but I think since we've reviewed her a couple things have happened. It's Tiffany Richardson. She has final pathology pending. She had a D&E yesterday, but an NIPT with a high risk of trisomy 18. And then certainly some ultrasound findings consistent with trisomy 18. First seen on first trimester ultrasound with a pretty remarkable and clear hypoplastic left heart. She's had quite a few studies, but I'm just going to go over some images from her echo. Here, it's a little hard to see that the fetus was moving quite a bit, but this is supposed to be a 4-chamber view, so it's a transverse to the level of at the chest level of the heart. I remember, yeah.
Actually open smoothly.
There's another 4-chamber. So you guys can see this is the right side of the heart, the tricuspid valve. The right side is apex forming. You can almost not even see the left side of the heart. It's so hypoplastic here, and the LVOT was really difficult to appreciate. This is her early echo at 16 weeks, and it was after this visit that she decided to terminate. One other thing I wanted to point out.
The brain had a problem. It looked abnormal.
The head overall was a really abnormal shape. And then there was, let's see. One other thing that we saw was abnormal hormones. It's hard to flag them. Oh, they're
Clenched.
clenched and overlapping digits as well. And you can really see it. It's really so here. This hand is definitely clenched. You guys can see those digits there. I had to get a 3D. You see that overlapping digits here? Yeah. So I just thought this case was interesting. She had a D&E yesterday with family planning, and she unfortunately had a hemorrhage that required transfusion.
This is the 16-week, the last ultrasound. This placenta looked normal, but when you were showing something in the brain, either it was a subchorionic hematoma or something abnormal placenta. See, this one, I don't know what that is. See those bubbles above?
Yeah.
See the bubbles.
Maybe a leak.
So I don't know what that is.
What was her NIPT?
It was high risk harassment.
ET? Yeah. Okay, so that makes
Yeah.
sense with the.
Yeah, and she declined diagnostic testing. She wanted the products of yeah, she wanted POC. Sorry, she didn't want like a CVS frame.
You know, a few things regarding the genetics.
And then this 3-vessel view also, you can see how
Obviously,
pulmonary is.
you know, so you're thinking trisomy 18, you know, you don't know if it's an narrowed NIPT, you know, if it's mosaic, if it's full trisomy 18. Obviously, when you have a complex, very complex cardiac anomaly, clenched hands, you know, like a lot of things going for trisomy 18, then you think, you know, the positive predictive value of an NIPT begins to be like over 90%, you know, if you look at the walks, like a walks and talks, like a trisomy 18, so to speak. You know, I also always think about, you know, it could be mosaic, you know, maybe the heart, the hands, you know, a few things have the trisomy 18, maybe it's the brain doesn't, you know, if the brain looks okay. You know, trisomy 18s can have major brain anomalies, obviously. But I guess for her, the heart findings made the difference at the end in terms of deciding. Did they send genetics on the remaining?
They did, yeah. And then she did unfortunately have a decent hemorrhage. I mean, this was her 6th pregnancy, I would say. And she stayed overnight. She got actually brought back to the for evacuation of Beecham. She stayed overnight. She got transfused units. That's FFP and red. And this morning she's feeling well.
So she's here at Jefferson.
She's here at Jefferson. She had her DNA with Dr. Vinay. I'd be familiar with this patient too. So she presented to us also. She's a G1. G1P0 this is a follow-up of an anatomy scan, but I'll go over her anatomy scan, which is the one prior to this, at 20 weeks. She presented to us for like uncomplicated first trimester NT scan, was found to have what we think is a ruptured omphalocele with liver and small bowel herniation. And that was really the only finding. She had a low risk NIPT and declined diagnostic testing. And then obviously AFP was elevated. She presented to us for her, and she desires to continue the pregnancy. Really, she is very aware of the increased risk of stillbirth. She's, you know, been counseled up, down, and sideways about what it would be like to see this baby born alive. Most likely they're not a candidate for postnatal surgery, just given the extent of the omphalocele and the involvement of the entire liver. She had a new finding at her anatomy ultrasound, which further complicates things and really affects prognosis, specifically in the ability to ventilate. So this is a sagittal view of the spine. And this, you know, when you see this on an anatomy, I think the first thing that we all want to do is make sure it's not just due to like fetal movement. See if we can ever straighten the spine out. Unfortunately, this abnormal curvature and scoliosis really persisted. And
Is there any semi-vertebral? I remember seeing this in the NT or when I saw her.
Yeah,
16
yeah, I know you saw her right before this. So this is a kind of 3D attempt at a coronal view. It was really difficult to get the whole spine in a coronal view because of the curvature. And I know this kind of looks like limb body wall, the way that it's facing belly down, but like there's many clips of it free floating. It's not tethered, like all the limbs are moving. So I don't think it's limb body wall, but I don't know what to make of this scoliosis. But it's quite impressive. So she has a couple issues. So her insurance is charging her a lot per every ultrasound. So we are not actually proceeding with an echocardiogram here because we gave her the option of Nemours and CHOP, and she's choosing to go with CHOP, and they will do like a whole day with her at the end of the month. I think it's scheduled for August.
Why is she being charged? Insurance related or why is she being charged?
Her insurance just has a really high copay. And she's having difficulty getting off of work. So we are not actually planning to see her anymore between now and her CHOP consultation. Her CHOP consultation could not be scheduled until she's unfortunately 24 weeks. And I've talked to her many times about, like the legal limit of termination of pregnancy in this state, but that she still has options in going out of state should she decide to do so. Her and her partner really have taken the stance of not intervening. So I think we're not really bringing up termination again unless they bring it up. This is just a transverse view of the abdomen. Up here you guys can see the whole liver is out, and so is the small intestine. Sorry, this is being very laggy. And here's other sagittal views. So you can see, I couldn't see any, I'm sure there may be hemivertebra present.
Well, I didn't see anything suspicious. It's just, I remember seeing the curvature and I just assumed that because of the abdomen content was out, it just forced the fetus to be in a weird position.
I thought so too. But I've also I don't know, Dr. Bullock had not seen like the status scoliosis with an abdominal wall defect before. I don't know if this has. I'm not sure if it's related.
Musculoskeletal position to bring new problem. Mobility arthrogryposis.
Yeah, so far no arthrogryposis. The whole spine appears to be covered. There's no posterior fossa abnormality. There's no neural tube defect that we can see. So, but it's just a really unfortunate and interesting case.
So for me to learn, is that's all this for a second frame? That's all vowels there.
I'll show you.
So how many weeks is she now?
This is 20 and 0. So this is small bowel here.
So
This is-
basically we don't need to see her that soon, just prenatal care, routine prenatal care. And
This
we can
routine
do
prenatal care.
inside heartbeats until she gets her consult.
Yeah, exactly. She's just routine prenatal care. She's gonna have her CHOP consult. I think she might not know until she knows, and I think they're gonna be pretty graphic with her about like palliative care measures. If any other measures could be taken, and that may or may not change her mind about terminating. So
I sat in with a genetic consult with her. I think the reason they brought up is religion.
yeah.
From my essence. She feels like she.
Couple of things, come to mind. Sorry to pick on you, Leshae and Eileen, but aborts, this will comes up all the time. They present you a non-fallow seal. What's associated risk of associated anomalies here? Non-fallow seal, how commonly it's associated, 5%, 10%, 30%, 50%, 90% ballpark. Yeah, something like that, depending on the series, but that's a good answer, all the way to 50%. And what about genetic abnormalities? How, I know she has a low risk in IPT and she's declined, but the council should say about 30% of them can have, genetic abnormalities, 13, 18. So, like, I think that'll be an important part to eventually, get the echo, to get an amnio if she eventually changes her mind, even for counseling, for management. I just looked it up, scoliosis and omphalocele trisomy 18, there's an omphalocele extrophy and perforated anus spinal defects, or EIS complex, limb-body wall defect, which probably she doesn't have. Beckwith-Whitman can come with both scoliosis and omphalocele. Spondylocostal dysostosis can come with both. Bacterial. So there's many, the list goes on. So there's many different things. That's why, I'm sure if Fuda was around, an exome even on somebody like this to find some of the stuff, or at least, some specific testing for some of the syndromes will be helpful in terms of counseling. The omphalocele itself, gastroschisis, do really well. Isolated omphalocele, especially smaller than this, can do well, but when you begin to see the scoliosis, the larger omphalocele, you don't even know the genetics, then you get a lot more harshness. I'm not sure that I'm ready for, palliative care. I don't know what they're gonna find and do a chop, but it's really a complex case. When you see an omphalocele, like, your red flags should be all right in terms of there's something else here. I need to find what else is going on, and the genetic.
Maybe it's like ruptured or ruptured omphalocele because of liver.
Yeah, because of how severe, how large it was and how early it presented. Initially so you can tell by like the ACI, the relationship of the like abdominal wall defect to the ACI sometimes. And it looks now that the baby's larger, that it is just like going right the ACI through this abdominal wall defect. So it's really like a midline defect, as opposed to a right-sided. And it's really, I think, atypical. So her risk factors are more gastroschisis based, in terms of like, she's like Latina, she's, young, she's G1, but her, presentation, like the fetal presentation is much more omphalocele, like, and how severe it was at, I think 12 weeks was when we first saw her. So that's, it really is arterial quality that suspected a ruptured omphalocele at first. And now, given the multiple anomalies, I think that makes a lot more sense. We just don't have genetics to really back that up at this point, but I think we will eventually.
Did you do an IVT?
Negative, low risk. I mean, really, that means very little. This is the last case. Maybe I won't say what's wrong with this one. Although maybe it's gonna be obvious. Anyone see anything?
Making it bigger.
So this is a 43-year-old. She's a G2P1, and she presented to us for an anatomy ultrasound. Routine. Looks abnormal. No.
We keep playing answer. Maybe like spine is not as smooth.
Yeah.
And based on the labeling, and also it looked like there was
based on me labeling a
yeah,
it's
fine.
but let me go.
But there does look to be like a.
What part of the sign do you think it's in?
Sorry, can you play again? Cervical.
Yeah. So this is a really strange case. But I think you can see it best in this view here, the sagittal view. So these are all sagittal sweeps. And what caught my eye was like this little divot in the lower part of the C-spine. Yeah, sorry. Just AS is like freaking out every time I do something.
Can everyone see that? Right up here.
And you can also, use this one to,
I can scrub.
bring it to where you think it's most helpful.
Yeah. So we took a lot of sweeps of many sagittal views of the spine. Right there. See that? That little divot. And at no point could we make that look normal. You see it?
Transfers.
And let me go to different views. So after you see an abnormal spine view on a sagittal view, you want to make sure you look at it in the other planes. So we looked at it in transverse, which was really difficult to see anything, but then we looked in the coronal view and took some 3D images. I think you can see it best there, but do you see this abnormal curvature of the C-spine? Yeah. It was really hard to pinpoint where exactly this was, but I suspect there's a hemivertebra in the C-spine. And it could be, I know I gave a field therapy on this like a couple months ago, but essentially like the vertebra, the bony vertebra can be fused, it can be malformed, it can be like a butterfly shape, a block shape. It's usually unilateral and it creates like a scoliosis. I didn't see any other abnormal curvatures in any other portions of the spine. And there was no abnormalities in the posterior fossa, which is another thing you always want to check anytime you see a spinal abnormality. So weird. I have never seen an isolated cervical spine hemivertebra. So we recommended that she have an MRI, which she's being set up for, and a fetal echo, and then genetic counseling as well.
We see normal movements, head, arms.
Head, arms, legs. So, I counseled her that best case scenario, this could just be like a minor scoliosis, something you might not even, be able to appreciate, or it could be like noticeable. It could limit movement. It could require surgery in the worst case.
Could also be an artifact.
It could also be an artifact, and this could be completely normal. So we're gonna investigate more with the MRI. I think Alexa was working on getting her insurance approval for that yesterday in a peer-to-peer.
I wonder if there is something, would that affect the mode of delivery?
So I started to talk about that with her. Dr. Al-Kwatli seemed to think that it probably wouldn't progress to that level of the spine, the head not being able to flex.
Especially because it's on the C-spine.
Yeah, but when she pushed me to worst case scenario, I was like, I guess in a very bad case, it's stuck and it can't perform the movement.
Can it flex?
If it can't flex and extend. I don't think it's gonna get to that point, but I think it's a non-zero chance,
Reasonable question.
Yeah.
So the MRI says.
We'll see. I don't know. I just couldn't get it to be normal looking. So yeah. That's all I got for ultrasound.
Thank you.
Oh yeah, you can see it here, like that little. It looks like it's.
Zoom in on that.
Is it leaning toward the side of the defect, do you think?
Oh yeah, you can see right there.
You see, it's kind of
It's like a
crooked.
yeah.
Yeah, it's just kind of.
It's like a right angle.
Yeah. It was kind of subtle, but I obviously I caught the sonographer's eye too, and she took a lot of.
There's a reminder when we are doing, and I sent an email to the sonographer's file when we're evaluating placenta mapping for Akita, especially in an placenta previa. Please pull bladder, because otherwise we will not see the bladder interface. The last Akrita cases have had empty bladders, and it's difficult to assess.
Yeah, I've been trying to remember before they take the patient back to not let them.
I sent them a message, please pull bladder, don't send the patient to empty the bladder.
Yeah.
It will take a long time to fill in the bladder again and assess again. But when you're evaluating a placenta previa, transvaginal, pull bladder.
I have a few outpatient case I want to discuss. First one is Miss Crone. She's a 41-year-old G13P6066 at 25 and 0. Early on in pregnancy, she was diagnosed with thickened NT at 3.2 millimeter at more than 99 percentile. Initially she declined any kind of genetic screening, counseling, or testing. In this pregnancy, we had a normal no growth anomaly on her early ultrasound at 16 weeks, and then again at her detailed ultrasound at 20 weeks. Currently, we want to ask the question to the group is, right now we are already getting serial growth ultrasound, but in the setting of
She also had a.
Oh,
fetal
sorry,
echo.
I advised her yesterday.
Yeah, go ahead.
I counseled her yesterday, and I don't have a great reason for this, but I said weekly at 32.
I think you're fine with that. It's just, with the increased risk of demise, we just don't know how.
Yeah.
It's early. I think that's great.
Yeah, I think she's gonna be here a lot. She's not super excited to come weekly at 32, I will say. I think realistically her schedule is gonna allow weekly at 34 because she lives pretty far. I think she lives in Longwood, New Jersey. But she's willing, I mean, she tried to like schedule it out to pair it with prenatal visits and ultrasound, so I think it'll be okay. But yeah, we had talked about it yesterday and scans surgery.
Yeah, we were leaning towards earlier, but this is great. Yeah, that's what we're thinking too.
For NT counseling for the other fellows, the old, Nicolaides table is really helpful, which is in the scan unit, which tells you the risk of, having a normal baby, stillbirth, other anomalies, cardiac anomalies, et cetera, et cetera. So the risk of stillbirth, I'm sure at 3.2, it's elevated, really would warrant, NSTs. The issue is a lot of those stillbirths are in babies that not only have the abnormal NT, but also have trisomy 21 or, some other chromosome anomaly. So what really, to make a decision like this, I would love to see, which I think is easily available, an NT like this one that has, as far as we know, a normal karyotype, no other structural anomalies, no fetal echo, and I'm sure the stillbirth is still increased, but then if there was a genetic abnormality. So just something to keep in mind. This was a somewhat arbitrary, decision to decide, but that's the kind of data that should inform. I think that the NST indications in general have stemmed in the last 20 years mostly from not that NST is saving babies, but this particular condition is associated with increased risk of stillbirth, and therefore let's do NSTs like BMI over 40 or AMA or other things like that. And certainly an elevated NT is associated with
Recent article in the White Journal about this, like a systematic review.
Very possibly, yeah. Again, that's what I'm encouraging.
Yeah, I think the stillbirth, I don't remember how they categorized it, but I'm pretty sure it was 9% risk of stillbirth, but I don't know if
Still with that's pretty high.
I think so. I might. Let me look it up.
Yeah.
But I remember looking at this very recent. Okay, next patient. To let the group knows the patient was seen in Plus Clinic. This is Ms. Palantir. She's a 33-year-old G2Ps 1001. Currently at 12 and 3. She has a known long-standing history of chronic hepatitis C, likely contracted, had vertical transmission through birth since both of her parents were IV drug use. She herself does not.
This has been known, in the past 8 years since she tried to donate blood and was detected with this condition. When we saw her with Dr. Dutra in Plus Clinic, we discussed with her, the data regarding, starting treatment of hepatitis C in pregnancy. That currently there's no large trial, but there's a few smaller trials that has shown great outcome with 100% SVR after completing treatment with no significant, with 0 birth defects or any association with fetal demise. So she was given the option of starting in pregnancy, and we're waiting on confirmation of her genotype to start her on one of the on Harvoni dual drug medications, direct antiviral. And that was just an FYI. We don't have a posing question, but I do, Dr.
Sorry, I missed the hepatitis C. What about treatment?
We are initiating treatment in pregnancy. Okay. Yeah.
That's huge. So, Carla Dutra organized that?
This is hepatitis.
She's 12 weeks.
Oh, she's 12 weeks. Yeah. The plan, we're basing this on the prospective case series of this study, the largest one so far in India, about 27 patients, and they achieved 100% SVR after completion of medications during pregnancy. We are planning to start her at 20 to 24 weeks, making it it is a 12 weeks treatment with a plan to complete by 36 weeks because we don't have data on breastfeeding and she wants to breastfeed. And 3 months after that, we will check her viral load.
And the treatment we're giving, how different or similar is it to whatever she will get if she were not pregnant?
It's the same treatment.
It's the same exact treatment.
Several,
One drug or 2 drugs?
2 drugs. There's several treatment options. It all depends on her genotype. She known about this for 8 years, but throughout the last, few years, they think, oh, you're cirrhosis. You don't have cirrhosis. Your level's not bad enough. Oh, you're pregnant. We can't start. Oh, afterwards she was postpartum. Well, you can't start because you're breastfeeding. So it's been a long time coming for her. I'm just glad.
And who's prescribing the drug? I've been waiting for this day for about 20 years. Holy cow, what a week.
500,000. Yeah.
Unbelievable. That is fantastic news. Fantastic news.
She was happy about it. She kept asking, so how bad does it have to be for me to get treatment? Because she kept being told it's not.
Yeah. It's curative, and
Again.
Talking about things, sorry to be personal. My very best friend in Italy, whose mom died of hepatitis C. I saw her, 20 some years ago, and now we can treat it. It's amazing. From a transfusion. Wow. That is great. Good for Carla.
Next is a patient. We do have a question to make sure the group agree with our assessment. So 1 second, let me go on. So this is a patient we saw yesterday that was already seen in ultrasound a couple weeks ago. Miss Frazier, she's a 33-year-old with a complex obstetric history. So first is in her first pregnancy in G1, she PFOM at 35 weeks and then had underwent C-section in G2 in 2013. This pregnancy was never recorded and was found out yesterday. Looks like she appeared to be going to preterm labor at 20 weeks. She said that she was having, a bit of cramping, a bit more pain. She went to the hospital, and by the time she arrived, she has significant pain and delivered the baby right away. In G3, which occurred last year, she endorsed that she absolutely had no pain at all until the day of arrival to the hospital. That prompted her because she has a gush of fluid. She shortly had, after that, had a lot of vaginal bleeding, found to have 3 centimeter dilated with fetal part in the vagina. They did have to evacuate 100 cc of dark clots in her vagina, so likely eruption after PPROM, unclear. We don't have any any clear, picture of cervical insufficiency for this pregnancy.
So far, she was seen at ultrasound and given just the previously known just the one history of PPROM. And shortly after abruption preterm labor, she was recommended to have serial cervical length screening at 16 weeks. Now with another history, a poor obstetric history right before that, we were wondering if anyone feels strongly about history indicated cerclage, given that she now has 2 outcome of delivery at 20 weeks. What we have gathered so far is that the first poor obstetric history is more, it sounds like preterm labor, but it's so many years ago, we don't have any records of this from Temple anymore. The only record we have is just a placenta pathology. We don't have much notes regarding how she presented, but in her knowledge, she had some pain, and by the time she goes to the hospital, she had the baby. And no history last time. She's 16 weeks today, so we're kind of out of the window, optimized window for history indicated. Her last cervical length last week is all normal. Her next one is next week.
What was the cervical length this week?
3.1 centimeter. Do you feel strongly about continuing?
The way I think about this, just for, again, some of the fellows and stuff, I was thinking about, so what's the risk of her needing a cerclage anyway? And for example, I'll just give you.
Need this Anju's study?
Say it again?
Anju.
Yeah, Anju study, actually, that's one of the ones I'm going to bring up. So, if you take singleton, right? If you take, no prior preterm birth, so a no lip or something, and you're looking at, is she going to shorten, right? So, the incidence here is 1 to 2%, maybe 3% here, Jeff. It's pretty low. If you have a prior preterm birth, just one, whatever, the incidence goes up to 40%, right? Much higher. So the question is here, if you have somebody like, with 2, 20, 21 week losses, so to speak, how, it's higher than 40%, how much higher it goes, and what, for example, Amanda's bringing up, we did a study, if you have a prior ultrasound indicated cerclage, right? So you've had a cerclage before, and you deliver that pregnancy at less than 32 weeks, right? We had a few like that, 100% will have a short cervix, right? So somebody like this, why would you do cervical length screen? Like, she's going to get a cerclage anyway. You might as well do a history indicated cerclage. Does that make sense? This kind of thinking. So that's the way I think. Like, this one's, certainly you should follow cervical length here. There are some studies, you could do a history indicated cerclage or cervical length screening, and the outcomes are the same. But here you only do 40% cerclages. So 60% never get cerclages. We follow with cervical lengths. And that's why we do this. Here we should place a 12-week cerclage. In this case, in general, most of the time we've done, I don't have the data, if you want to do a study, we could certainly do a study. I would think her chance is probably 60, 70%. So if she was 10 weeks, I would say do a 12-week hysterogated cerclage. You can do a hysterogated cerclage anytime, 20 weeks. And so obviously knowing that she's 31 millimeters, now that's reassuring. Maybe that 67% is a little bit less now. But there was a 16 weeks.
She's 16 today. Yeah, 16 and 2.
So I would still lean towards placing a cerclage because I think the risk
is strongly desire cerclage.
She would consider it if we offer.
Are we offering?
I think we should offer it. I think patient history.
My personal philosophy is that when a patient strongly desires cerclage, I explain the risk benefits, but if she still wants a cerclage, I will not going to deny a cerclage Because when you don't do it and something bad happen, they're mad at you, they yell at you, and they sue you.
Yeah, yeah, and another thing that was very controversial is, so we're talking about two, right? So with one, let's say, again, second trimester loss, many times we do cervical lens screening because, again, the risk of a short cervix is maybe a little bit more than 40%, but not that much more. And we've studied that. But ACOG said you should offer a history indicated cerclage to someone even with one early preterm birth, let's say preterm birth less than 32 weeks, like in this case. So I think if it's one, I think definitely we should discuss it and document it, that history indicated cerclage could be a management. I personally disagree and was very upset, I guess I can say that, when they say this. But with two losses, I think there's a lot more evidence because, with two losses, again, the risk of a short cervix is going to be pretty high. So even if she's 31 millimeters, I think she still has a pretty good chance that she was short.
That sounds good. I will circle back to the patient and offer, discuss risk benefits. Thank you.
That's actually a study I've been wanting to do forever. It's harder to do now because a lot of these people, do get cerclages, like, women have a lot of natural history. But we do have plenty of people with two losses, one loss that we follow with cervical lens.
I attended a study where history of advanced cervical dilation or physical exam indicated how to treat next pregnancy. But here we always offer cerclage. We don't like we always do. I couldn't find a case where we're offering. I think maybe one who declined the cerclage, and they were after physical exam indicated.
Oh, yeah.
What to do next pregnancy.
But what you're talking about is another group.
The sample size was really more. I did the project with Gabriele. And because Italy don't do automatic cerclage, so they were doing cervical link, and 80% of the cases had cerclage in the Italian group, but there were only 8 patients. So I have like 10 patients and 8 patients, and I needed more cases. So maybe we can review that again.
Yeah, and maybe do it with other places.
Now we have
You have to help us understand this.
Yeah.
District, for one.
Yeah.
Why do you so disagree with ACOG?
Because if you look at the randomized trials on history indicated cerclage, almost none of them have included the patient population. So a lot of the patient population, if you look at the details, like, if in 92, the biggest trial, unfortunately, is from, 30 years ago in Europe. And that's the one that said you have to have 3 prior losses for a history indicated cerclage to really.
3 prior second trimester losses?
Yeah, 3 prior early preterm births or second trimester losses. That's what the, MRCOG study showed. And that was like, a couple of thousand patients, really large. So if you look at instead other randomized studies, with only 1 prior preterm birth or 1 pregnancy loss or things like that, and if you do cervical lens or history indicated cerclage, the results are the same. And again, the majority, like 50-60%, never shorten, so they never have a cerclage on the cervical lens group. So I'm like, we can save cerclages in some of those patients, and the ones that need it anyway, cervical lens is very effective. I mean, I don't want to get too much into this, but so if you're talking about sensitivity of the test, right? So sensitivity is how good is cervical lens at predicting, preterm birth. In other words, if you're gonna have a preterm birth, how many times cervical length is gonna catch it? Like, and here it's only 30%.
Sensitivity at serial cervical lengths or at the anatomy ultrasound, like where?
I'll study it, here as a single, here it's serial, cervical lengths. So singleton, no preterm birth. Very few will have a preterm birth, but some do. We screened them once. Of 10 preterm births on this group, 3 will have a short cervix. 7 will not have a short cervix. They will deliver because they have preeclampsia, because they have an abruption, because they got parvovirus and the baby delivered early. So it's not very sensitive. Here, it's 70%. Very different. So the vast majority, so if you have 10 preterm births in a lady with a prior spontaneous preterm birth and a singleton gestation, 7 out of 10, you're going to pick them.
Mm-hmm.
Okay. And the more you move here, the more sensitive it is. So again, if you have an early loss or too long, like this lady, if she's not going to shorten, before 24 weeks, she's going to go to term. It's very sensitive because probably her losses are due to a weak cervix. They're not due to, something else. I don't know if that makes sense, but I think this is really important information that the sensitivity goes up, 80, 90%, never going to be 100. The worse your history is. And so that's reassuring to me that cervical lengths are really good for our sickest cervical insufficiency patients.
There's no difference in outcomes in terms of like weeks gestation.
Yeah, prenatal mortality. We did a meta-analysis a few years ago. Sorry. There are 4 randomized studies, and we did a meta-analysis. The biggest one is from Europe. Again, there were people with all 4 randomized studies, prior preterm birth, second trimester loss.
Times 1.
No, many had more than 1. Okay. And we all mix, 1 or more. They didn't do a sub-analysis. We couldn't do a sub-analysis. 1 or more. And again, they were randomized history indicator cerclage, cervical length screening. Again, as I said before, about 40% shortened and had cerclage in this group, right? But the outcomes were the same. Prenatal mortality, preterm birth, 28 weeks, 37 weeks, 34 weeks, etc. So here, you're going to have 100% cerclages, right? And here, I think it was 42, in this meta-analysis. And that's why I say, like in a patient like this, I'm actually saying maybe she should have a history indicator cerclage. But if you have only 1, going back to this, I think this data is pretty reassuring. Oh my God. All right. Where were we? Sorry if we went on a tangent. We talked about this, but any other outpatient you need to talk about? No, that's it. Okay.
Time for German Club. Yay! Leshae's going to present our German Club. What is everybody else? Huda, Whitney, Rocha?
Whitney has been on.
She's in New Jersey.
Yeah.
Bamotis also.
Go ahead.
Dr. Wally's on vacation.
Oh, is she?
And so is Dr. Bullock.
Oh, I didn't. Okay.
Okay, no problem. Wait, yeah.
I was like, what is that? Either way, I pick up this topic.
All right, so I'm Leshae. We all know And I'll be talking about this article, the induction of labor versus standard of care to prevent shoulder dystocia in fetuses suspected to be large for gestational age in the UK, known as the Big Baby Trial, a multi-center open label randomized control. So some background, shoulder dystocia is typically defined as impaction of the fetal head at the time of vaginal delivery, requiring other obstetric maneuvers for delivery of the shoulders. And we know that it's associated with serious maternal and neonatal risk. There are antepartum risk factors that we have identified in kind of being able to predict shoulder dystocia, which includes LGA babies, maternal obesity, excessive gestational weight gain, diabetes, advanced maternal age, history of shoulder dystocia, postpartum pregnancies, and male fetal gestation. There is a limited high-quality evidence of whether proactive interventions like induction of labor or suspected macrosomia can safely reduce these complications. So this slide here helps us to kind of talk about why the Big Baby Trial is important. So when we look at the literature on induction for suspected macrosomia, we see that very few studies, I've highlighted them here, look at induction of labor prior to 39 weeks. This table here was adapted from one of the most recent retrospective cohort studies, systematic review and meta-analysis by Bard in 2024. And even though these studies have evaluated patients for induction of labor prior to 39 weeks, their sample size were small, the studies were heterogeneous, and the measured outcomes were inconsistent, as you can see here. Additionally, for all the studies that were included in the systematic review and meta-analysis, there were different measurements of macrosomia. So some were measured by ultrasound, some were measured by birth weight. So there's discrepancies in the existing literature that we do have. So the Big Baby Trial tried to address these limitations by randomizing a large cohort to induction, specifically at 38 and 4 weeks gestation, and identified standardized outcomes by using a well-powered prospective design to try to provide high-quality evidence to offer more definitive data to determine if early induction is something that's feasible in macrosomnic babies. So some important information as we kind of transition into talking about this trial. So in the UK, they don't typically do standard screening for LGA. So in terms of ultrasound assessment. So their process essentially looks like they kind of do serial assessments and plotting of fundal heights. And if there's any discrepancy or size trajectory that is noticed, then they refer the patient for an ultrasound to assess biometry and EFW. However, patients who are at an increased risk of growth disorders, so like patients with diabetes, they are offered serial growth ultrasounds. So the study objective of the Big Baby Trial was to investigate whether early induction of labor is associated with a reduced risk of shoulder dystocia compared with standard of care, which I abbreviated as SOC. And I wanted to talk a little bit about trial definitions because there's a lot so that we're able to kind of follow the results and methodology, et cetera, as we talk more about this study. So for this study, shoulder dystocia was defined as a vaginal cephalic birth that required additional obstetric maneuvers to deliver a fetus after the head has been delivered and genital traction has failed. LGA was defined as greater than the 90th percentile by ultrasound. Macrosomia was defined as greater than 4,000 grams. They used two different analyses for the primary outcome. We'll talk about the primary outcome here shortly, but the intent to treat analysis included all randomized participants with available outcome data in the groups to which they were originally assigned, regardless of protocol adherence. Per protocol analysis includes only those participants who strictly adhere to the assigned intervention. Standard of care was defined as the hospital's usual care And then definitions for postpartum hemorrhage, which we'll evaluate for some of the secondary outcomes of the study. So primary postpartum hemorrhage was defined as blood loss greater than or equal to 500 mils. Major postpartum hemorrhage was defined as blood loss greater than 1 liter. And we'll talk about the GROW chart, which is essentially a customized chart that was, so they have this program called the Growth Assessment Program in the UK that essentially aims to improve the rate of antenatal detection of SGA fetuses and reduce the rate of stillbirth. And the GROW chart has been shown to help also identify LGA babies, and it has a stronger association with predicting adverse outcomes for non-customized population average standards. And this specific GROW chart kind of is customized for maternal weight, height, parity, and ethnic origin. And this is something that is commonly used at NHS maternity units as part of this growth assessment protocol. So the outcomes of the study, the primary outcome was the incidence of shoulder dystocia. The secondary outcomes included gestational age at delivery, birth weight, duration of hospital admission, and other neonatal and maternal peripartum outcomes from routinely recorded data, so like birth trauma, prematurity associated problems, postpartum hemorrhage, we already talked about the definition, and perineal lacerations. The number of adverse events and serious adverse events were compared by trial group, and then the study data for maternal and neonatal charts were analyzed separately.
Remind me, what growth curve did they use?
Oh, yes, we will talk about it. So we'll get to it in future slides, but for assessing head circumference by parietal diameter, abdominal circumference, and femoral length, they use Hadlock 1985. And for EFW, they use the GROW chart. And we'll talk about that more when we get later into the presentation. That was a great question. So 3 composite outcomes were assessed in this study. They looked at intrapartum birth injury in the form of fractures of upper extremity bones, including the clavicle and long bones, and then brachial plexus injury in the neonates. They looked at prematurity associated problems, such as the need for phototherapy and respiratory support, and then maternal intrapartum complications in the form of 3rd and 4th degree lacerations, cervical lacerations, and then primary postpartum hemorrhage, which is greater than 500 cc. Study exclusions. So they excluded multifetal gestations, non-cephalic presentation. The study excluded diabetes pre or gestational diabetes that was managed with insulin or an oral agent. And the reason they specifically excluded this patient population was because the recommended delivery timeframe was before the 38 weeks. So it actually started at 37 weeks, the 38 and 6 weeks. So that's why they were excluded. They excluded anyone who had a contraindication to induction of labor, anyone who had a planned elective C-section, planned induction of labor or indicated induction of labor, planned home birth, imprisonment, current psychiatric condition requiring antipsychotics, history of stillbirth, inability to give informed consent, and then known fetal or serious abnormality. So that was their exclusion population. So when we talk about how they kind of decided what their patient population, their sample size, etc. So they essentially used the incidence of shoulder dystocia from a large RCT by Bulvain, since the incidence in the UK was unknown. The Bulvain trial actually showed that there was a 2/3 reduction of clinical significant shoulder dystocia, and that allowed the authors to say that 50% reduction in shoulder dystocia incidence would be like a plausible target. The incidence of shoulder dystocia in the Bulvain trial was 3.9, and that trial included patient populations in France, Belgium, and Switzerland. So these current authors rounded it up to 4%. And they determined that 3,252 participants were required to obtain that 50% reduction in clinically significant shoulder dystocia using a significance of 5% with a 90% power. However, because there's an uncertainty of the incidence of shoulder dystocia in their study population, the authors increased their sample size from this 3,252 to an estimated sample size of 4,000. So that was their goal. They had an independent data monitoring committee that monitored data throughout the trial to be able to terminate recruitment once they achieved a sufficient amount of participants to answer the research question. However, recruitment was stopped after October 2022 after interim data analysis showed that actually over 12,800 participants would be needed to achieve that 90% power. So the study was temporarily stopped at that time due to those reasons. So now we can fully dive in with all of the background that we talked about. So the Big Baby trial, the study timeframe was from June 8th to 2018 to October 25th, 2022, and it was a prospective phase 3 open label parallel group multi-center RCT. They recruited patients at NHS hospitals across England, Scotland, and Wales. 106 NHS hospitals were included. Eligible participants were approached after an ultrasound showed an LGA fetus between 35 to 38 weeks. And we said that LGA was EFW greater than the 90th percentile by ultrasound. And then to Dr. Roman's question from previously, for their biometric measurements, we said that they use Hadlock's formula, the 1985 version, to derive the measurements of the head circumference, BPD, abdomen, circumference, and femur. And then the EFW percentile was derived from that growth software that was kind of individual, customized based on those variables that we talked about before. So we can see here that they had 25,000 patients that were assessed for eligibility. After excluded patients, we had that further come down to 7,151. About 2,500 patients were eligible but not enrolled. And then we'll talk about the separate cohort study in a few slides, but essentially these people were kind of excluded from randomization. So our final randomized number was 2,893 patients. Individuals that were eligible for randomization, they had a mandatory obstetric agreement to be able to participate in the trial. They were offered information and invited to have detailed discussion with trial site midwives and obstetricians about the trial. Midwifery is very big in the UK. And then potential participants identified had sufficient time to consider the trial, and they informed consent was obtained for all participants. So when we look at the randomly assigned participants, we can talk a little bit about how this was done. So they were randomly assigned using minimization, and that was to help ensure that their important confounders were evenly distributed, and the randomization was 1-to-1 using an online tool, using an online tool known as the Bespoke Online Web Tool that was developed by this clinical trials unit as listed here. And then for the minimization, things they used to account for, they balanced them by site, EFW, whether it was greater than or less than or equal to the 95th percentile, or maternal age, less than or equal to, greater than or equal to 35 years of age. In looking at this table, and I apologize that it's blurry, I try my best to make it visible. In the induction of labor group, we had 1,447 patients, and in the standard of care group, we had 1,446 patients. We can see in each group, we've had patients that were not induced per protocol or not delivered per protocol. And that's where we'll talk about the different type of analyses that this study used for the primary outcome, which was the incidence of shoulder dystocia.
So on the standard of care, so induction, obviously it's clear, 38 and 0 and 38 and 4. The center of care, what did they do? Did they just wait till 41 weeks, 42 weeks?
So they actually advise, and it might be the next slide, but
Sorry.
no, you're okay. Those are great questions. They
Whatever.
no, that's okay. They kind of advised against induction initially prior to 39 weeks and 4 days to try to create a gap between the induction group, between the induction group, which is 38 to 34. So that's what they intended, and their intended mean difference in birth weight was 300 grams. No, you're okay. Please pause me anytime. So prior to randomization, maternal health quality of life data and routine demographic data were collected. And to ensure allocation concealment, the people enrolling participants in the study ensured that all baseline measurements were collected. Participants and their clinical teams were actually not masked to treatment allocation, no blinding. It's hard to blind induction of labor. And the randomization process, like we said, was handled by that tool, and participants after randomization, they knew exactly which treatment allocation they belonged to. A copy of the delivery notes of the randomly assigned participants were evaluated by an independent expert adjudication panel that consisted of a midwife, a junior and senior obstetrician, and a neonatologist. At least 2 members of the panel had to review each participant's delivery notes, and if there was a discrepancy, then all of the panel was consulted. And of note, the panelists were masked to like patient identifiers, essentially. So they had no details on site or participant details or details of the antenatal care that was provided. This kind of answers Dr. Bergella's question. So they tried to ensure that they can create a significant gap in gestational age between the trial groups. So induction of labor prior to 39 weeks and 4 days was discouraged unless there was a clinical indication. And the authors aimed to have a 1.5 weeks of gestational age between the trial groups that resulted in a birth weight of 300 grams of the mean difference in birth weight. Interestingly, there were very few participants with missing data, so they didn't have to do any imputation or sensitivity analyses for the study. The authors collected data on infant and maternal outcomes with a postnatal questionnaire that was provided via telephone at 2 months and 6 months of delivery, which was really interesting. And then some participants, you remember that 1,666 patients that were in that parallel cohort study, they essentially, after being counseled on the risk of shoulder dystocia with induction of labor, decided to have an elective C-section. And some patients also declined randomization because they wanted to choose which groups they wanted to be assigned to. So they were offered to have a parallel cohort while the main trial was undergoing. And I'll have those results after we talk about the main trial data.
Sorry to, but it's an important thing for some of you who will do or are doing randomized trials. Could you tell from the study, if you didn't want to be in the study, could you elect to have a 38-week induction, or there was only through the study? I couldn't tell. Maybe we can email Dr. Gordosi. Because a lot of times when we've done studies, like, you get, like, you're not gonna be allowed to have.
Here, you will not be allowed to be in the use or have C-section for 39 weeks until you.
Yeah, or twin short cervix, study if it's not you can have a cerclage outside the trial.
They commented on that group of patients, but more on terms of like outcomes, but not on
yeah,
like the parallel group. They essentially just mentioned
like here in the US will be against ACO like we'll be get dinged by the quality and safety people, for doing an induction too early without, a line. Just curious.
Well, that's a great question. I would love to hear what they say. Okay, and then more on the study methodology. So we talked about what the per protocol analysis was. It was performed for the primary outcome and consisted of all randomly assigned patients. And then participants who had missing data for the primary outcomes, so long as the proportion of missing data was less than 10%, they were excluded from the analysis population without imputation. And the study did a lot of analyses. They did a subgroup analysis for participants with early BMI, pregnancy BMI less than 25 or greater than or equal to 25, or an AFW less than or greater than 95 percentile. All of the secondary analyses adjusted for site, EFW percentile, and participant age, and then they use regression diagnostics and model fit to assess primary and secondary analyses. And then once the statistical plan was agreed upon, it was signed by the data monitoring committee before the database was locked and final analysis was done with data. Okay, the results. So for patient demographics, we can see that the mean age between groups, the induction and standard of care groups were the same. Most of the patients, and this is an adapted table with kind of the things that are like pertinent to talk about. So the table is way bigger than what is presented here. But most of the patients were nulliparous. They were from British European ethnicity, and a significant population of the patient population were either overweight or obese. The GDMA1 population did not take up a significant population of the study. And then you can see not a lot of patients got antenatal steroids. Not a lot of patients were smokers. So for the primary outcome, the two different analyses are presented separately. So of note, statistical analysis was based on complete data, and for the cesarean sections, shoulder dystocia was counted as no. And again, the results were adjusted by site, maternal age, and EFW. So for the intention to treat analysis, they found that the incidence of shoulder dystocia was 2.3 in the induction of labor group versus 3.1 with a non-significant reduction. And while the per protocol analysis showed that there was a significant reduction in the incidence of shoulder dystocia, it was actually a 38% reduction in the incidence of shoulder dystocia. Additionally, in the per protocol analysis, we can see that patients in the induction group were delivered 8 days earlier, and their babies weighed 213 grams less than their standard of care cohorts. If you look at the intent to treat analysis, the numbers are different, and that's because there were dilution of differences between the two groups, because some women who were randomized to the induction group may have spontaneously delivered like earlier or later, and some in the standard of care group may have been induced early. So those numbers have a diluting effect. And these, I think, are the true numbers because those patients adhered strictly to the protocol. For delivery timing, the induction of labor was slightly increased. Induction of labor slightly increased the total hospital stay by approximately 0.4 days. And the time spent on the labor ward was increased by 2 hours. And that kind of makes intuitive sense. Patients undergoing induction of labor, they need more time. They're admitted earlier and they spend more time in labor. There's longer time to progress, etc. However, the post-delivery length of stay did not differ significantly between the groups. For delivery characteristics, we can see that participants who had the use of vacuum for vaginal deliveries was less with a significant p-value. And then patients who needed like elective or emergency C-sections, those in the induction of labor group were also less compared to the standard of care group. For maternal outcomes, we can see that women in the induction of labor group had fewer primary postpartum hemorrhage. And then this was interesting. There was a slight increase in second degree lacerations, uncertain as to why, but there was no significant difference in third and fourth degree lacerations. And then for the composite maternal outcomes that the authors sought out to kind of identify, was actually lower in the induction group. For neonatal outcomes, there was actually no statistical differences found in the secondary outcomes between the two study groups. Of note, one neonatal death occurred in each group. The neonatal death in the standard of care group was due to perinatal asphyxia after shoulder dystocia, and the other death occurred in the induction group secondary to sepsis and congenital pneumonia. There were also 2 cases of HIE. Those babies received therapeutic cooling, and there was no concerns at the 6-month follow-up. There was no significant differences in fractures. And there were 2 cases of brachial plexus injuries in the standard of care group. One was transient, associated with shoulder dystocia, and the other was not associated with shoulder dystocia and was treated with physiotherapy and recovered by 6 months post-delivery. So for their subgroup analyses, I put this in a table so it's better to kind of comprehend. Thanks to Dr. Roman. When we stratify the results by BMI, we can see that patients with a BMI under 25, induction of labor significantly reduced shoulder dystocia with a p-value of 0.04. And also led to a larger drop in birth weight compared to standard of care. For those with a BMI of 25 or higher, induction still did show a lower birth rate, but the reduction was smaller and there was no significant difference in shoulder dystocia. So overall, the benefit of induction appeared to be stronger in the lower BMI group compared to the higher BMI group. There was no difference in the EFW category. The authors did say that these subgroup analyses should be interpreted with caution because there could be different C-sections or differences in ultrasound accuracy between the 2 BMI groups. Now the parallel cohort study. So essentially what we can see, so I put the N here so we can compare. We see that the mean age they were older, so 31 versus 28.8. A higher percentage of those patients elected for a primary C-section or elected for a C-section. And then they tend to have larger babies compared to induction and standard of care groups. And I think this is like a good real world kind of representation, and the results from this kind of highlights how like counseling, maternal characteristics, facial preferences kind of play an important role in patients like making decisions. Now the follow-up, so they had a pretty good patient follow-up in both groups at 2 to 6 months. And when they compared maternal and neonatal outcomes at 2 and 6 months, there was actually no significant differences between them. So in summary, induction of labor at 38 and 4 for macrosomic babies or LGA babies showed a significant reduction in the incidence of shoulder dystocia from 3.7% to 2.3% with a 38% relative risk reduction. There was a significant decrease in elective cesarean rates, significant decrease in emergency C-sections, significant decrease in forceps-assisted vaginal deliveries, and postpartum hemorrhages, no significant increase in adverse maternal outcomes, and there was no significant increase in neonatal outcomes. These findings support individualized shared decision-making for the timing of delivery in suspected LGA pregnancies, as induction of labor may reduce the risk of shoulder dystocia if done as planned without increasing the risk of cesarean or major maternal and neonatal. The strengths of this study, they had a large sample size, largest sample size known to kind of address this topic. Multi-center design that covered a lot of UK hospitals. They've had a really good follow-up and data completeness for reliable outcome assessment. They had robust randomization and minimization procedures that enhanced the internal efficiency of the study. They utilized independent mass adjudication panel for primary outcomes to help reduce bias. And the inclusion of the parallel cohort along the main site RCT helped us to enhance real world context and enhance generalizability of the results. While the study has many strengths, some of the important limitations to note are early trial termination due to the lower expected shoulder dystocia rates, statistical power. The open label design introduces potential performance bias. However, they kind of for that by doing the adjudication process with the masking of the panel. A substantial portion of the standard of care group actually delivered earlier than planned, diluting the difference in gestational age and birth weight groups, likely contributing to the non-significant result in the intent to treat analysis. And then the accuracy of ultrasound-based fetal weight estimation is limited, and some patients may have had unnecessary interventions. The generalizability of the study is moderate to high for the UK and similar settings, given the multi-centered design and expansive inclusion criteria. However, they excluded diabetic pregnancies and relied on the GROW charts, which we don't necessarily use in our patient population. They also used the Hadlock 1985 version, and to my understanding, we use Hadlock 1991. So it could limit applicability to patient populations that don't necessarily use the things that they did. And my last thought, while they were doing the big baby trial, they also had a health economic evaluation that was reviewed separately. So this is the paper that came out of it. Like the is it cost effective to induce labor early to prevent shoulder dystocia, evidence from the big baby trial. And essentially what they found was early induction resulted in a higher combined maternal and neonatal cost compared to the standard of care. And they saw an incremental cost to prevent one case of shoulder dystocia was £11,000, and the incremental cost for maternal quality of life screening was $39,500. And when they looked at cesarean sections, it seemed that cesarean sections may lower the short-term cost. However, they did not have any long-term kind of data on outcomes, neonatal and maternal outcomes. So I just thought that was interesting to include. These are my references. That is all. Great.
Keep the references real quick. The second one, Bulbain, that's the author of the big, French trial. We basically found the same results. The data in general seem to trend towards, 30 weeks. I think in this case, they even included some 37 weekers.
We did 37 weeks.
37.
It's big because
Yeah,
the
go ahead.
increase in neonatal outcomes with that specific trial.
Yeah.
And so that was the concern.
Yeah.
So they just
Well, here
But
they
they chose 38
Fine.
because of Dr. Bergella's in 2016 or 2017.
Yeah.
That essentially said, consider 38 weeks, given that, with that meta-analysis, there was only 4 studies, and the Bulbain study had majority of the patient population, so it was kind of skewed towards that. But because they included patients that were 37 weeks, we know that patients at 38 weeks were less likely to have when they did a subgroup analysis. So that's why the recommendation was consider at 38 weeks. So then this study decided to do 38 weeks based on the Cochrane review and then the meta-analysis.
I didn't have time to review the other studies designs. Were they also designed as intention to treat, including even the elective C-sections?
Yeah.
They were
Because,
also intention to treat.
I mean, I think when you primary outcome is shoulder dystocia, and you also enter into the analysis elective C-sections, you're shooting yourself in the foot to have a bad outcome. And the overall result is like the trial was negative and also got stopped shorter than the intended sample size. When in fact, when you look at those who achieve vaginal delivery, the induction of labor decreased shoulder dystocia. So for me, it is a positive trial that if you manage to push out ahead, your shoulder dystocia risk is lower. In general, elective C-section was decreased, indicated C-section in labor was decreased. So for me, it's a very positive trial. But the idea in general, even I Googled it and I saw TikTok things and YouTube things, and everybody's like negative trial. It didn't work. It didn't work. When in fact, it was very positive.
There's a lot of dissent from midwives
Of course, I guess.
in the UK.
Mhm.
I was like reading about that.
There was a midwifery.
Yeah,
Like,
Against the trial.
they were against the trial. There
podcast.
was, there's been a lot of criticisms of this
Trial
study.
yeah, there was a podcast and it was a midwife talking about, and it was just trashing the study when I think the study is extremely positive. If you go back to the result.
Yeah, there's like this,
Like avoiding one case of shoulder dystocia is hugely.
No, like for example, if you look at the parallel trial, the elective C-section rate was 16%. While the elective C-section rate in the study was 4%.
Yeah, it was less than 5.
So if you offer them a chance to have an earlier delivery to decrease the risk of complications in labor, more women are going to say, yeah, I want to try a vaginal. And women were scared of, I have a big baby, I'm not going to push the 9-pounder.
also mean birth weight is decreased too
Yeah.
as a result. of
Bleeding
that.
risk.
Yeah, but it's,
Hemorrhage is decreased.
as far as I don't cause any harm, the babies were not admitted more or having complications, broken bones or bilirubins or glucose. Everything was the same.
Yeah.
So I think that,
The only difference was that there was like a half day longer admission was the.
which is difficult to
Yeah.
tell, because when you run on a patient at 8 a.m. and you tell her you're ready to go, they don't go within the hour. The difference was what, 4 hours in the discharge?
Half.
And patients go home whenever they want. So that you can put them out of the, like a hotel. You're due to charge at 10 a.m. or you're going to be charged another day. They don't leave. So that is skew your data of discharge. I don't know what they do in UK.
The labor was 2 hours longer, which has been shown over and over, reduce your labor maybe a little bit longer.
It's nothing.
Only 2 hours.
I mean,
Yeah, like
There's
clinically.
multiple patients in this scenario in scans recently.
Yeah.
that
Asking about it.
were asking about this, who want to be delivered.
Yeah.
It pains me to tell them that this
Yeah.
is not standard of care right now. And that we haven't adopted this basically
Yes.
as a division or an institution.
like I asked them, what is your major goal? Like,
You're waiting on me to finish the stupid guideline. I have it done.
Major goal.
You're working on it.
Dr. Bergella, do you see how many tabs I have? This is literally what I've been spending the past days.
Yeah.
It's just
So-
reading through all of them.
After Sicily,
No, I'm getting it done. I already have a
Don't do
plan.
it in
I'm
Sicily.
doing it now. I'm gonna stay up. I'm gonna pull 24 tonight. Get this done. I'm gonna send it to Leshae to edit, then she'll send it to you. Then when I come back from Sicily, we'll go over it because OB guidelines was canceled for tomorrow. So
Yeah,
I
I
have to
know.
get it
That's what I was gonna say, yeah.
So when I reviewed the study and I reviewed the slides yesterday with Leshae, I was extremely excited. Why we're not doing this? Decrease C-section rate is our major goal in obstetrics.
And I was told on this again for everybody, a lot of new people around the table compared to last time I talked about this. When we did the meta-analysis and everything else, I was already convinced 38 weeks is the best time, but received resistance, at the guideline meeting, etc. Now we have 3,000 more patients, randomized with the same results. So I always think, if my sister, my daughter, my friend, as a 3,800, 4,000 estimated fetal weight, and she's 37 weeks. I think next week she should deliver. If she wants a vaginal delivery with a healthy baby, based on the data. The fact that, I told you this before, ACOG has this 39-week rule. It's been harmful, in cases like this, for example.
I have a question though.
ACOG will revisit the topic?
I don't know, but they should. Yeah.
So the Boulding paper induced between 37 to 38 and 6. This paper trial did 38 and 0 to 38 and 4. And the other studies did.
I think it was 37 and 0 to 38 and 6.
Was Boulding.
Yeah.
This one is 38 and 4 to 38 and
4, which is, I think, what should be recommended, if you're gonna do it. This is
the US study was after 37, and then the other two were like somewhere in 30. I feel like based on the results of this study, based on the meta-analysis, after 38, but do we just say 38 to 38 and 4, 38 and 6, 38 and 4? Based on the
this is
results.
one of the larger trial focused on 38,
Offer induction or recommend induction?
interview.
I think it's
We
okay.
say,
But there is no emergency, it's like a right trial.
No.
I offer, we don't want to find.
that is being able to offer it and not be linked if they say yes.
Right. Just for the wording for the
Offer.
offer. Yeah, that was my thought too.
I have a question about like the ultrasound data and then also the birth weight data. Like, did it mention like if how off they were, or like if they? I feel like I always quote people like, "Oh, it could be plus or minus a pound," and
They did not comment on like the discrepancies.
But if you look at the result, they are all deemed to be EFW more than 90 percentile, but they're actually the birth weight more than 90% were only 50%. So this is something we discussed with a patient where accuracy is 50%. So you could be smaller or larger, mostly smaller 50% of the time. So you can decide whether you want.
But if you're like inducing early, then you expect the birth weight to be less.
Yeah, but I've seen it in clinical settings. We said small and then or normal.
Right.
And so patients don't want intervention. And one patient told me, last pregnancy, you told me it was going to be a 9-pounder. I got induced and the baby was 7. So this time I don't believe you. And I'm going to take my chances with this continuous onset. It happens.
Yeah.
And people get disappointed, as well as people may elect to have a C-section and then end up being a small baby. Or smaller than expected. And then they feel disappointed. I had a C-section for now. So I think this is the population we need to target. Is being targeted, as you see in the parallel group. 16% elected to have a C-section, likely because the baby was too big. So this is the population we're targeting. If you are concerned about big baby, let's deliver you a little bit earlier, so you can achieve vaginal delivery.
This is another important point, on this slide, following what Amanda is saying. So LGA babies, right? So there were 41%. So LGA babies, so the neonate, the birth weight, they were thinking of the 100%, right? They were above the 90th percentile for, and only 41%.
Yeah, across the trial, 41% compared to the parallel.
So another obviously thing, that's big elephant in the room is we're not that good, at predicting LGA babies.
Even with this new statistical approach where you correct by BMI and height and everything, they corrected for all possible things, it still is 50%.
Yeah. And I'll tell you what's going to come up, which you're going to publish on tomorrow, next week. AI, lots of papers on AI. You put maternal BMI, cheek size of the baby, fetal sex, genetics of all kinds of things, and those obviously, if you put more variables, usually you can be a little bit more sensitive, more precise and specific, in terms of prediction, because that's, disappointing. Maybe it doesn't work because almost 60% of the babies were not that big. And they're going to deliver vaginally anyway, even at 39, 40 weeks. So that's kind of another, corollary that, you should keep in mind. It's interesting that the birth weight in the inductions, well, we know that, where 200, I guess here it's 200
Yeah, I was
grams.
about 213.
Yeah, 215 different.
This is the per protocol though, right?
Yeah, per
With
protocol.
the
Yeah.
intention to treat, I think it was like 168.
Yeah.
Yeah, it was not that bad. The discrepancy was not that bad.
Yeah. Do you have the gestation age of delivery exactly in each group?
Yes.
The slides. No, the results.
I think it was like less than 7 days.
For
eight-
intention, it was 6 days. For
Yeah, they were open for 10 days and it was 6 days.
protocols
The intent to treat
For the
Intention to do is 3.
and then
So 270
276.
versus 276. 6 days difference.
Apparently most patients agree to be induced at 39 weeks rather than our population. It's like 50-50. They want to wait for spontaneous labor up till last weeks sometimes.
Yeah, that's kind of what I was getting to. And another thing I'm thinking about, a lot of people say, I'm 30 weeks, how much my baby's gonna gain. And half a pound, a little bit less than half a pound here. That's probably what if these are non-diabetics, something to keep in mind.
But we can change. I mean, at this moment, we cannot induce anybody. Ryan will go to the meeting and he's going to be voted for inductions and then we'll be in trouble.
But at least
promise, tomorrow morning, guys.
At least we're unanimous.
You need to go to April and convince.
With momentum.
The goal is to decrease this section and the next accreta, because we had an accreta with 16 liters of blood loss. So we don't want that. And as you remember, this lady had only one prior C-section. The lady for next week also had one prior C-section.
You don't have to.
So you don't have to have 5 prior C-sections. And we're going to have 6 prior C-sections coming. So we're trying to decrease the first C-section and the accreta is the way to go. I actually convinced last week somebody who wanted an unmedicated spontaneous onset of labor and the baby was 97 percentile. It was like 4 kilos already. So I convinced her to be induced and she's coming today for induction. I'm tracking her progress.
39 weeks.
39 weeks. So I convinced her, like, do you want a vaginal delivery? Then let's induce you as soon as we can. So they were open. And the diabetic lady who got C-section yesterday, we predicted 9-8 last week, and baby was born 9-5. Tamika Gilmer, she was big and desperate to get delivered. So she got delivered at 37.0, and the baby was, in fact, 9 something. We were off for
39 weeks. Very good. Should we do some blurbs?
Yes, we shall.
I emailed Gordos, if you have any questions about this trials, let me know. He's on vacation.
I think probably the induction, like what modes of induction they used for.
Mode of induction as well? Sure.
No, for us, see us. That I need to get this done tonight. Oh my God.
Okay.
So the blurb today is about monochorionic twin gestation, kind of in response and further discussion in response to the new article that just came out at CES. It came out in Greens 2 months ago regarding management and surveillance, during monodi. Let's start with that first. I'll kind of leave there for people to read because it was a dense paragraph, and then we'll go into a few things we want to discuss. This is meant to be shortened for AS.
Yeah. I think so far it's the same way we had it before. Oh, what did you remove?
The grammar.
Oh.
Yeah, just.
Do we have? I think we also have increased C-section rates on twins.
Okay, I had it in the other. I'll add it here. The epic blurb would expand a bit more.
I can see the difference between this and what I have been written it for years.
Caps is different.
Perhaps.
Yeah, we didn't have that in our office.
Okay.
I don't know if this is needs to be there. I just added in there. I feel like it's kind of rare. Or do you know kind of
It's very rare.
okay. I mean, just yeah, to be a first consult.
So I think, most recent
Yeah.
data says that it's actually 10% incident, not 15%. I know we used to have 15, but corrected to 10. If you go back, I would, I don't know, it doesn't make much difference in terms of management, but I would put it, and because that's what most of it doesn't change, what we do. It's still 2 to 5 for TAPS is fine.
Yeah. I usually add on that the preterm birth is 60% to make it more dramatic. But
Another thing here, and again, I don't know if it even goes into it's how you do the 2020 screening.
So just kind of jump to the discussion of a new update, on so the author of that CES is Dr. Simpson, who is one of the author for the SMFM consult for updates on management of chorionic pregnancy that just came out last year. So in this document that just came out, the few things to discuss is that per this document, AIUM and ISUOC deem that monochorionic pregnancy is an indication for 12 to 14 weeks detailed ultrasound. I know across the board, that's just not, we haven't, something that we currently adopt in our practice. But just so everyone's aware, this is their recommendation.
We don't routinely include MCA Dopplers right now.
We don't. So then the next thing to discuss is that both the SFM consult and the CES document recommend TTTS every 2 weeks, starting at 16 throughout delivery, which I think that's what we've been doing. The added portion is with consideration of MCA Dopplers to screen for TAPS and DV Doppler if there's any atypical finding or suspicion of cardiac dysfunction. We just list a few, at least all the indication that I suggest. So I guess the question we just need to discuss as a group is, how do we feel about this recommendation that has now been both addressed in 2 major documents?
So, again, the in the attending meeting yesterday, we even discussed, doing fetal anatomy ultrasounds at 2 weeks or so for everyone. They're starting to offer that at Abington. High Valley does them as well. I think Christiane is starting to do them. That's something outside of 22 transfusion that is coming our way. I think we could, personally, we could add that, here that monocyte twins, given the high risk of anomalies, should have some kind of anatomic survey early, 12 to 14 weeks. So I'd be in favor of that.
So consider or
consider early anatomy scan. I mean, that's something that think within a year or two or less.
Talking about only mono.
Yeah, for now, I think just a mono dye, just this thing. And then the issue is 2 nutrient screening starting at 16 weeks. And then I will put a comma, including what you include, in that second bullet, including what you do, what you check specific.
Yeah, evaluation of the bladder fluid.
Yeah. So, yeah.
Unless we're trying, are we gonna do?
Well, let's get there, bladder, well, fluid, right? The first thing is probably fluid to put in. On each side, that's obviously on each side of the membranes, that's fine. Bladders and umbilical artery Doppler, which again, not everybody even does. But I think we probably should, because there are some cases in which you can have no bladder, no more fluid, and no umbilical artery Dopplers. I feel less strongly about MCA and lactose venosus. We don't do that.
Yeah, I think we discussed how do you diagnose TAPS if we don't do it.
You have to be really vigilant about the liver appearance, but you can miss it.
Yeah.
It's really, I don't know. I'm like conflicted about MCA. I've asked a couple of my friends if they do it at their programs, and most people are not universally.
I think CHOP was sort of surprised that we didn't do it in the last
They're certainly surprised, but they also do like cardiac index.
Yeah, they do the cardiac index. But the thing is, CHOP take care of the referrals, which are the worst cases. So they do a comprehensive evaluation, but they were like, why will you guys don't do MCA?
And remember again on the teaching side of this, if you screen something, then you have to be ready to do something about it. If you have an abnormal MCA, what are we going to do? A transfusion, or I guess for us, it's going to be a referral to the MORS and or CHOP. I will keep it like this. I feel bad that there are no more attendings around. I think unless there is strong feelings, we will keep it at this. And any other suggestions for these 2 points?
No, I think these 2 points are mainly, this is more.
So as MFM say, we're going to provide incorporated upper MCA in all MCOs, but then we should add it. Not that I
feel that's MCA Doppler.
Let's say that.
I think we should do it.
Well, then put it in.
I think we just, because then we could increase our frequency of surveillance, I mean, then we can get detailed images of like the liver, we suspect TAPS.
Should we do liver length and all mono?
Liver length?
Yeah, how are we going to look at the liver?
It's supposed to have a different visual.
It's the starry sky. Starry sky of hepatic.
Yeah.
Have a teaching point because I don't know what am I looking for.
I have some pictures from that conference I went to last year with Katie and CHOP. They did like a whole thing on.
So we need to learn about it.
Yeah.
And the appearance of
Next therapy, liver texture.
Yeah.
So Adams.
Then let's do that, and next to come is liver texture.
So
this
then
is
we
also
would
gonna
do
be
MCA Dopplers at the same time with TTS every 2 weeks. I didn't.
Right.
Yeah.
If we're gonna actually recommend this, we have to tell our stenographers because they're not routinely getting.
Yeah. When we
get education.
I think, and again, so not there on top. Glucor and MCA. Make the changes, circulate it to everybody, included attendings or attendings missing for the table today, and then say, we need a week turnaround unless we have strong propositions that will.
I think at least now we are compliance with the 2 major documents.
Yeah, absolutely.
What about the cervical length? Many years ago, we agreed to do at least 2 cervical lengths. I wrote the guideline, it was posted, and we'd never do it. Cervical length at 16, and depending if it's normal, then at 20. The problem is the number needed to treat is very low. I mean, you need to scan a lot of patients to diagnose one. Very high.
Yeah. I'm okay with it, Amanda. As you know, Moti, Amanda, and others are working on a study, but we know already the results that, it goes back actually to what we were discussing before.
So if you only do universal cervical length, I think the incidence of short cervix, only 1 at 20 weeks or somewhere between 18 to 22. I think the incidence of short cervix was like 3 to 4%. But if you do it serially from 16 to 22, then you go up to 12%, which is not too much, but technically you triple the chance of identifying somebody with short cervix.
Well, do you want to wait till? I just feel bad for their attendance. That'd be okay, but Moti is gonna present that soon.
I don't believe it. Sensitivity and specificity is low, but the other problem with the study that we have is that all short cervixes got treatment.
Right.
They got Besarixar class, progesterone, so you cannot calculate sensitivity and specificity in a population that got treatment. You skew your data towards the outcome. So now you cannot calculate the sensitivity of preterm birth. You just need to determine that the incidence of diagnosis and accuracy of the diagnosis, but not the sensitivity specificity. And I told him this 100 times, and he's still fixating on his sensitivity and specificity. That is no value in this.
So I will circulate this in the group. The other is just the EPIC blurb that expand more. Like Dr. Roman said I had in here, well, I think it was already there, but more than 50% chance of pre-birth with more numbers.
Yeah, so you have 8 to 12 here, which I think is. Yeah, I mean, make the same changes we made to the other one. I don't think here we're gonna be more.
And I will add in here also the early anatomy.
Yeah, early fetal assessment.
Yeah, just copy and paste from.
That's the other thing. When we schedule somebody for twin-to-twin transfusion check, they just do the pictures they need, but they don't do an early anatomy. They don't do growth. Should we be doing growth at 16 for these ones?
We start TTTS at 16.
We should.
Yeah, but not necessarily growth.
TTTS should include an early anatomy. Is that what
Like an early anatomy and a growth evaluation.
I thought the recommendation was from 12 to 14. Do we?
Yeah. So 12 to 14, we put it in early anatomy. Then every time it's more than 3 weeks from the previous ultrasound, the sonographer is going to do a growth.
Yeah. So the 16-weeker needs more time, so they can do growth, early anatomy. Yes.
You want to go back up to
Can the early anatomy just be at the time of like?
I'm just trying to tell you because it's 12 weeks. Yeah.
I know, but you don't get enough information at 12 weeks to clear the anatomy until 20 weeks. And if you had the patient here.
So then
you can do the NT the early anatomy.
So technically they should have growth at 16 and early anatomy.
You go back.
So NT 12, early anatomy 14.
No.
No, just one ultrasound.
At 16 when they come for the first.
NT 12.
I mean, technically it's supposed to be early anatomy NT at 12, based on the recommendations.
Okay,
16 is when you start TT.
And then 16, and then another early anatomy at 16.
Just change the top.
Okay, so NT early anatomy.
Go back. Go back. So you do it only once. Go back to.
Do the sun.
the
And
blurb.
then regular.
Yeah.
3 anatomies.
So.
Anatomy.
But I think if we're doing that,
Well, the 16 is.
I mean, like when you'll see when you're in scans, if you have like a sub, you're gonna see everything. Like you're gonna sub off things, but you don't have them keep coming back every couple days to clear
We
it.
should also make
That also,
an anatomy blurb. on
yeah,
it.
yeah,
Like, that is something.
that's a separate thing,
Agree.
separate thing, so keep it this way.
We're opening new tabs.
We're doing screening every 2 weeks, sort of 16 weeks. Maybe you can put in parentheses, including growth every 3-4 weeks. Before until. Parentheses, including growth every 3-4 weeks.
But if you
Isn't
just
that-
put in the including evaluation of this, and growth when appropriate, just write and growth when appropriate,
Sure. Fine.
instead of having to like,
As appropriate doesn't mean anything. Can we say every 3-4 weeks, which will.
as indicated. Every 3 to 4 weeks.
As indicated could be once.
And then we start fighting.
0 could be every 8 weeks. Like, yeah, when you do guidelines, I think you need to do, or whatever, you need to say what you know, if you say serial, it doesn't mean anything.
So every 3 to 4 weeks.
So why don't we just do every 4 weeks, so it bunch up with a TTS interval every 2?
But if they're FGR, then you're gonna have to change.
Yeah.
So then just do every 3 to 4.
And that's different, because we need like people doctors.
3 to 4 weeks encompasses that.
But are we trying to talk about like normal twins, you know?
I think this is all
I feel like if we're reaching into the category of like FGR twins or abnormal twins, then they get much shorter follow-up.
These
We
are
can
more
recommend
like-
it to everyone, right? I know, they're troubling. But what I'm saying is like, this is the blurb for what we presume will be a normal, healthy, chorionic, diamnionic pregnancy. We shouldn't like start to drift into when things go wrong,
Let's
right?
see.
Like selective FGR,
Um,
TTT.
12-week NT, TTTS 16 to 32, anatomy 20. Echo? What happened with the echo? Echo. Uterine growth 4 weeks, every 4 weeks. Fetal echo at 22, and anesthesia 32, and delivery at 34, why to 34?
So instead of putting the growth above, since it's repetitive, you would say serial growth also 4 weeks starting at 16 weeks, which then covers the growth, and then you can take growth there.
I think that's.
If twins are healthy, are we going to deliver them at 34?
That's just the window of.
Just the window, ACOG, the MFM.
Okay.
That's good.
You know, some places don't deliver monos at 36, they deliver them at 34.
Yeah, the range is
It's included.
7 and 6.
All right, next. So you're just gonna copy and paste the above
Yeah,
to
I'll
the consult
the-
blurb.
expand it.
Those are, your recommendations are gonna be there. And then mono, there you
This
go.
one is a little long, I would think.
This is way too long for
Yeah.
ultrasound blurb.
Is this it?
I'm thinking of just.
That could be more for.
You could keep it in the epic, but
Yeah,
in the consult, not.
because they're gonna
What is
need
the topic for
counseling.
this one? Again, this is mono. Oh.
Sorry, let me.
But I think they need this long blurb at least once. You don't need to copy it every single ultrasound, but at least
No, but like maybe this is more appropriate for.
a consultation.
Yeah.
Do we bring all of them to consult?
Like mono should be followed.
I think this whole second paragraph can be taken out altogether. Let's.
You just keep it for the epic consult blurb.
Yeah, I will keep that for the expanded blurb.
Let's see the recommendation, which is always, where.
So on this guideline, the only thing that's different from what we've been doing is we give a bigger range of inpatient management. I think you would say 24.
That's what we've done, I think. And you can put growth ultrasound starting at 16 weeks, you know,
These are monochorionic twins. They should also
Mono.
have DTTS checks as the previous one.
Agreed. And an early anatomy.
It's kind of forwarding a lot of the same information.
so just copy from above.
Serial growth, that should cover. And sorry, we're continuing TTTS until delivery, right? We're not like
Until
stopping
delivery,
at
yeah.
32 or anything.
That is what the both of the two documents
Central delivery, no,
So
for
delivery.
32.
is what was recommended by SMFM. I mean, it's the same author.
The thing is true. The TTTS doesn't go away at 32 weeks. And there is also the higher risk of acute TTTS. This is the reason for the demise.
This is very minor, but something that I keep on thinking about. So we always talk about lung maturation, but it's not lung maturation, you know, like steroids decrease,
It's
IVH, decrease neck and stuff.
Yeah.
So can we say for fetal maturation?
Fetal benefit.
Yeah, fetal maturation is fine. Just again, it's not just RDS, you know. Fetal death is decreased.
Just take IH.
But yeah, make it look somewhat similar to the one above, except for the delivery timing.
Do I put like genetic counseling, genetic testing, NT at this in these blurb?
I mean, this should be also in
Yes,
the
why
most die.
why
Die, because they have more genetic abnormalities as well.
And you want it there too? No, I think it was just left out. Yeah.
Well, we should recommend a genetic consult for everyone.
Okay. We'll clean this up. And
What else do you have?
just the two monochorionic.
Oh, I have AMA. Really, it's very AMA. It sounds so mean.
AMA above specific 35.
It's stratified 40, 45, 50.
We have a patient who's 53 and another one is 40 something, 45. We have several 41s.
I'm going.
So right now we have the AMA over 35 or more, right? That's gonna stay, and then there's gonna be another one.
For those who are over.
Is that over or
40
or
and
equal to
over.
45? Probably over and equal.
No, it's equal to and over.
So we're doing anesthesia for sooner for 45, 34 weeks.
This is up for discussion. It gets into it down here, but there's an increased risk of stillbirth.
I have not find any, there is a paper in the 45 and above group, and I think I find another one in the 50 and above. But then nobody recommends earlier delivery, despite all these risk factors.
I mean, I think now everyone can have a delivery at 30. But you're right, nobody recommends it delivery. But oftentimes they achieve an earlier delivery.
They have been.
So going one by one, or growth ultrasounds, almost everybody gets a 32-week growth.
Yeah.
Do we need to do more growths?
Yeah.
Are we okay with 32?
I'm really hoping. If they don't have any other indication, healthy 45-year-old woman should have a 28-week ultrasound.
You want to do 28 and 34?
Well, I like 28 and 32 or 34. I guess it doesn't.
What is the risk of the
FGR.
risk of FGR? Yeah.
Actually not listed in the meta-analysis. I sent it recently. Let me find
There's
it.
SGA. So in 40, 20%, in 45. Oh,
So this meta-analysis.
I mean, if 20% is
there. It's there's a meta-analysis that I took all these from.
Super.
I have.
We can leave 32 weeks. I'm just bringing it up for discussion.
Yeah, so high.
20% is pretty big.
Meta-analysis.
So you want to do 28 then 30?
I feel like a leap for 2 makes sense.
Sounds good.
Because
Let's do that.
it's a pretty
28,
big
34.
amount.
I mean, we
yeah.
do that for BMI over 40.
Yeah.
Yeah.
So
Then NSTs, okay, 34 weeks.
Why 30? I mean, this is from the old blurb, right? It's 34.
From the old
What
blurb.
it shows in.
we did 34.
Yeah.
32 weeks, you want to do?
Yeah, 34 is just,
Yeah,
It's
32.
like, when do we ever start?
Yeah, 32. If we're gonna do that.
Makes it too complicated to remember too. Okay, 32 weeks. And I think delivery 39 weeks,
Yeah. Yeah.
I guess we can
39
figure sooner,
yeah.
unfortunately.
So if
Assuming there's no other
AMA, right, very AMA is like their only potential,
Yeah.
their only.
We were more, but also have more NSTs, which
What's the risk of
is indicated.
does it say like the risk of preeclampsia development
Yeah,
too?
I have it.
Yeah, I think I have it down.
It's increased.
Retentive disorder is 12% over 40.
You?
And then,
Okay. Exactly. You can see.
like relative risk.
I mean, the relative risk of
So
stillbirth is
it's-
so high.
Is 2.8.
Especially over 50.
Over 50, should we just do like
Over 50 is crazy.
stable? Because that's like 28, 32, 36. That's a really high number.
What is the number?
It's 3.72.
Perinatal mortality 5. That's very
stillbirth.
high.
I mean, because that's saying that there's essentially a significant amount of placental insufficiency.
And neonatal death 10 times more. Well, for you to know, we have a 51 or 53-year-old who you're going to see next Monday, who's requesting C-section at 37 weeks. Because she had C-section at 36 last pregnancy.
It's some chronic hypertension that's unclear.
She's,
Well, that one?
yeah,
Yeah.
I just found out she was in Pavinton. I don't know why she ended up here.
It's on anticoagulation for no reason too.
And she has an anticoag, you did her consult,
Yeah.
and she has nose bleeding.
Yeah. I literally told her, don't use
And
it.
syncope, and I called the husband and told him to stop the Lovenoxen, but. And you're going to see her on Monday, and what the question is, I need to get delivered at 37, and you're going to say.
So it sounds like we should stratify this based on 45 to 50, 50.
Yeah.
Is everyone comfortable keeping the same recommendations 35 to 47? So single growth ultrasound. And then NFTs as we normally just.
So here you have 45, 28.
Yeah, just, the blurb should be called then 35 to 44. Right? They'll change the title of 35 to 44 for that blurb, keep it the same, and here should be, 45 or more. And I mean, we could do cancer. I'd be happy with just this ones for now, instead of adding more than 50, 55, etc. But
Yeah.
you can certainly,
This is for AS, this top one.
yeah.
So we can just say growth ultrasound 28-34, and STs weekly at
Yeah.
32 weeks.
And
And
the
then-
delivery timing, delivery at 39.
Consider recommend.
I would recommend
Delivery at 39.
the birth risk and everything.
Okay, great. And then this is the epic blurb that I think can go more in detail into the specific population. So if someone's over the age of 40, 45, and then 50.
There's a McCurdy AMA.
Yeah.
I bet she's not saying too many
From Africa.
AMAs in the West of Africa. Within a good though.
This, I took out low dose because of our new. But daily aspirin.
Even 162 we still call low dose. But yeah.
Okay, I guess then.
You know what I mean?
People will like interpret it as.
It's technically low dose.
Okay.
Right.
Put it back in.
Just so they don't get
I think it makes
365.
people feel better than daily because then they're like, oh, it's contraindicated pregnancy 325.
Using the word low.
They freak out when they hear aspirin. Like, no, this is not. At least in the past month on clinic, they're like, 162, is this safe?
It's still low dose.
Still low dose.
Got it, okay.
Again, circulate so everybody gets to see, give a week deadline and then we can.
So I'm not gonna add a little in summary recommend for the 40 to 45 group. So if they're above the age of 45, then because we're changing our normal recommendations.
Yeah, just
So
copy
this
and
would be
paste.
from above.
Yeah.
And then 50. The rest are higher. Do we want to recommend, also, are we comfortable recommending 39 and O, like not a window to 40?
No.
And then do we want to do serial growths?
Yes.
I think so.
Starting at 28?
The risk of stillbirth
Yes.
beings.
It's 10 times, it's too high.
Yeah.
Stillbirth 3 times, but I don't understand why the neonatal, why the neonatal risk is so.
Also, maternal mortality of 40,
We want
that
it-
is
Do we
crazy.
want to increase like we do with GDM? Weekly, starting at 32, twice weekly, 36. Do you feel strongly about that? No.
I think weekly makes sense.
Mortality 42%, no, there isn't a problem with it, maternal mortality.
Do we do
42 times.
PPPs or NSTs at mainline, do you?
STs.
But then you're like, should you deliver at 37? But
And that's 39 and
And you
0
can
for
get
delivery.
pregnant with that.
Should I get
That
pregnant?
mortality is higher than a mother.
Alright. 40 times how?
We need to review this maternal mortality relative risk of 42. Sorry.
It makes sense though, because maternal mortality for, average. For younger women is very, very low, the moment you go from
No, but
to maternal mortality
the
to.
risk of 42 is even higher
20.
than cardiomyopathy.
Like, it's like,
Yeah, but it's still, it's too high. Maybe it's not.
Oh my gosh.
Again, it's a relative risk.
Yeah, but it's too high, 42 times?
It's really
They
high.
definitely have an elevated BMI. They definitely have hyperlipidemia. Everyone's on a statin.
Potential diabetes.
Like they're definitely coming in.
I still have some ones that are healthier than some.
I think Iclail is the only healthy.
She doesn't speak English, right?
No, she speaks, she's
And her husband is
Turkish.
not here.
He's on the phone.
But he speaks in English.
So that's another problem. She stays alone with language barriers. So if something happened to her, she passes out at home. That's his concern. She's going to die at home, found dead in the living room.
The living?
Yeah.
Do you use translator or her husband wants to? What is your interaction so far?
No, I think when she comes, I never seen her. She needs translator when she comes. Husband is working but available on the phone.
I would 100%.
Sure, what's
This
the
meta
Give you
analysis.
42%.
It's the baseline risk, in the population is 1 in 10,000, right? 0.1. That would be, right, so just relative risks are helpful, but you have to put it in
Translate.
perspective and translate it. And I would think that maybe that's what they found, something like this, that it goes up, but the risk of maternal mortality is still low. You're looking for the data?
I was looking at that specifically. You're on this paper too.
Like,
This paper, is this a Conan paper? Yeah, that's what.
like,
I can't remember it.
ladies have IVF pregnancy in another country, and on top of being 50, came pregnant with twins. Remember the Greek lady who was our?
Oh my God, she was like 53.
You have maternal death earlier, no? Where is maternal death?
50 with twins. Another thing that I think I couldn't find the paper, but there is a paper that said that more than 45 years old, you need a cardiovascular evaluation, meaning you need an echo. I was looking for it yesterday. I couldn't find it, but I think these women needs an echo.
Oh, do you want to recommend maternal echo and
I wish.
those
yeah.
over 45?
And if you said no, too expensive, or if otherwise healthy, at least AKG ProBNP, which will be cheaper.
If you're gonna do ProBNP, should we also get like baseline health?
I think so.
Yeah.
You need all her lab. I think when they come in the first trimester, they need this line.
I mean,
But if you're
it kind of
50.
feels like, yeah, it's almost like just early. It's
All
like
the
early
consults I
Exactly.
The
do,
risk is up there.
So
I tell them it's better to do everything is normal at the beginning, and they agree to do it. They don't do it.
It's computer. Because I'm cute.
Oh, there's.
Let's see, you gave us a lecture of the teenagers. We changed practice based on your data, so we need to review again the 45 years old and above. Because we see them, we have a 62-year-old pregnant. Twice.
another one? Oh,
No, the same one twice.
This paper got 114 citations.
Yeah, it did.
Jesus.
It's pretty popular.
Who's this one? Sacon?
Yeah, that Dr.
What do you
Brielle.
think about something like that? And everybody's gonna read it.
Yes, Dr. Roman,
Hmm?
45 and over.
Yeah,
AKG,
45,
BNP,
yes,
CNP.
please, CBT. I remember a patient that I told her you need an echo, and she didn't do it.
Well,
because
actually-
we had such a severe preeclampsia with cardiac cardiomyopathy. I was like, this is why I told you to have an echo.
you put an A1C in there?
I know, yeah. I asked Dr. Jackson, I want universal hemoglobin A1C, and she says no. Really? Too expensive, she told me.
So
For maternal mortality,
COG don't actually recommend universal A1Cs.
For TSA.
Yeah, you guys did it at Penn because it was part of a study.
But Abington does it, Township does it.
Yeah,
We did a IU.
A lot of people do universal.
Yeah.
Yeah,
First trimester A1Cs.
Like,
ADA and ACOG don't recommend universal fluency. We don't recommend for patients with certain risk factors. And then the question becomes, if you're in the pre-diabetes range, what to do.
1 hour.
Early 1 hour
Yeah.
is what some people won't do. But then like, is treatment necessary? Not.
If they screen positive.
Yeah. Like, do we see a reduction in UALs? Which the toboggan trial did show.
Diabetes is one of my least favorite diagnoses. I think it's made up. It's just like nothing works.
I was bored. I was like from pre-diabetes, freaked out, and asked Dr. Barash to prescribe me. He said no.
Metformin doesn't even prevent progression.
No, I know, but I was like,
It's like a made up
So,
disease. Like
we
it's
basically
an
threw out all
information
candy and ice cream. It's
Okay, I'll make this look pretty and send it out.
I looked at maternal mortality in over 45 in that study. And it's still like less than 1 in 1,000 in 45. Still, it kind of
looks exaggerated.
it looks exaggerated.
Yeah.
The relative risk actually found is 11. It's in that study, but the numbers are the percentage.
So yeah.
Great. Anything else? Any blurbs, updates, discuss? Sounds good. We could use half an hour. Relaxation. All right.
We met. I brought some candies from.
Thank you very much.